Question 1. Radiation biology. DNA damage and repair. During a course of radiation therapy, different types of DNA damage can occur in tumor and normal cells. One of the key factors in determining the cellular response to radiation is the efficiency of DNA repair mechanisms. Which of the following best describes the role of homologous recombination (HR) repair in radiation-induced DNA damage? A. Homologous recombination is the primary repair mechanism for double-strand breaks in the G phase of the cell cycle. B. Homologous recombination is a high-fidelity repair mechanism that operates primarily in the S and G phases. C. Homologous recombination is error-prone and contributes to radiation-induced genomic instability. D. Homologous recombination primarily repairs single-strand breaks caused by low-let radiation. Answer B. Homologous recombination is a high-fidelity repair mechanism that operates primarily in the S and G phases. Explanation: homologous recombination (HI), a crucial DNA repair mechanism that primarily repairs double-strand breaks DBS using a sister chromatid as a template because it requires an intact homologous sequence. HR is most active during the S and G phases of the cell cycle when D replication has already occurred. This mechanism is considered high fidelity, meaning it accurately repairs DNA damage without introducing mutations. Option is incorrect because HR is not active in the G phase due to the lack of a homologous template. Option C is incorrect because HR is not an error-prone process, but rather non-homologous end joining (NH) is more prone to errors. Option D is incorrect because HR does not repair single-strand breaks. These are typically repaired by base excision repair (BER) or nucleotide excision repair (NER). This question aligns with the principles of radiation biology, particularly DNA damage and repair, which are critical in understanding radiation oncology treatment responses and resistance mechanisms. Question 2. Clinical decision-making. Scenario-based palliative radiation therapy for bone metastases. Dr. Mehta is evaluating a 65-year-old male patient with metastatic prostate cancer who presents with severe bone pain localized to the AL vertebra. MRI confirms osteoblastic metastasis with no evidence of spinal cord compression. The patient has already undergone multiple rounds of systemic therapy but continues to experience debilitating pain. What is the most appropriate radiation therapy approach in this scenario? A. Stereotactic body radiation therapy (SRT) with 24 GI in a single fraction to the LL vertebra. B. Conventional external beam radiotherapy (EBR) with 8 GI in a single fraction. C. Total body irradiation (TBI) with 12 GI in 6 fractions. D. Brachytherapy with an iridium-192 implant directly into the affected vertebra. Answer B. Conventional external beam radiotherapy (EBR) with 8 GI in a single fraction. Explanation: for patients with painful bone metastases, palliative EBR is the standard of care. Studies including randomized trials, the G-Artagan-Estro guidelines, support a single fraction dose of 8 GI as an effective approach for pain relief with minimal side effects. Option is incorrect because SRT is typically used for oligometastatic disease where durable local control is the goal, not for widespread palliative treatment. Option C is incorrect because EBI is used for hematologic malignancies, e.g. leukemia before bone marrow transplantation, not for isolated bone metastases. Option D is incorrect because brachytherapy is not a standard approach for palliating bone metastases as it is primarily used for localized tumors in prostate, cervix, and other organs. This question evaluates decision-making in palliative radiation therapy, a crucial competency in managing metastatic cancer patients. Question 3. Treatment planning (IMIT) versus 3DRT in head and neck cancer in the management of locally advanced oropharyngeal cancer. Intensity modulated radiotherapy (IMIT) has largely replaced 3D-conformal radiotherapy 3DRT. What is the primary advantage of IMIT over 3DRT in head and neck cancer treatment? IMIT increases tumor dose while significantly reducing dose to critical structures like the parotid glands. B. IMIT shortens treatment time compared to 3DRT by delivering higher dose fractions. C. IMIT eliminates the need for image guidance and reduces setup time. D. IMIT is more cost-effective than 3DRT in routine clinical practice. Answer: A. IMIT increases tumor dose while significantly reducing dose to critical structures like the parotid glands. Explanation: IMIT is a highly conformal radiation technique that allows for dose escalation to tumors while sparing surrounding normal tissues. In head and neck cancer, IMiD is particularly beneficial for reducing dose to the parotid glands, which helps preserve salivary function and prevent severe xerostomia. Dry mouth are common. Vector 3DRT. Option B is incorrect because IMiD does not necessarily shorten treatment time. It may require longer planning and delivery compared to 3DRT. Option C is incorrect because IMiD often requires image guidance (IGIT) to ensure accurate dose delivery. Option D is incorrect because IMiD is generally more expensive than 3DRT due to complex planning and increased machine time. Question 4. Radiation dose constraints and organ at risk or management. A 65-year-old patient with locally advanced squamous cell carcinoma of the oropharynx is planned for definitive chemoradiotherapy. The prescribed dose is 70 Gy in 35 fractions using intensity-modulated radiation therapy IMiD. The radiation oncologist must ensure that dose constraints for organs at risk ORs are respected. Which following statements regarding dose constraints is most accurate? A. The spinal cord should receive no more than 60 Gy to prevent radiation myelopathy. B. The mean dose to the parotid gland should be kept below 25 Gy to preserve salivary function. C. The brainstem can tolerate doses up to 60 Gy without significant risk of necrosis. D. The larynx should be kept under 70 Gy to minimize the risk of long-term dysphagia. Answer. B. The mean dose to the parotid gland should be kept below 25 Gy to preserve salivary function. Explanation. In head and neck radiotherapy, sparing critical organs at risk ORs is essential to prevent severe toxicities. Spinal cord. The maximum dose should be 45 Gy, not 60 Gy, to minimize the risk of radiation myelopathy. Parotid glands. The mean dose should ideally be kept below 25 Gy, as doses significantly increase the risk of xerostomia, severe dry mouth. Brainstem. Dose above 54 Gy significantly increases the risk of brainstem necrosis, thus 60 Gy is unsafe. Larynx. While dose limits depend on location and fractionation, doses exceeding 5055 Gy to the supraglottic larynx increase the risk of long-term dysphagia. These constraints align with quantitative analyses of tissue effects in the clinic guidelines. Question 5. Stereotactic radiosurgery SRS and tumor control probability. Stereotactic radiosurgery SRS is used to treat a patient with a 2.5 cm solitary brain metastases from non-small cell lung cancer. The radiation oncologist must determine the optimal dose fractionation scheme to maximize tumor control while minimizing toxicity. Which of the following is the most appropriate? Recommendation based on clinical evidence. A. 18 Gy in 1 fraction, as this provides high tumor control with minimal normal tissue toxicity. B. 30 Gy in 5 fractions, as it reduces the risk of radiation necrosis while maintaining local control. C. 45 Gy in 15 fractions, as fractionation reduces brain necrosis significantly. D. 54 Gy in 30 fractions, as this regimen provides better tumor control while preserving neurocognitive function. Answer. 18 Gy in 1 fraction, as this provides high tumor control with minimal normal tissue toxicity. Explanation. SRS is an established technique for treating limited brain metastases with excellent tumor control. 1824 Gy in a single fraction is standard for lesions 80%. 30 Gy in 5 fractions is often used for larger lesions, 3 cm, to reduce radiation necrosis risk. 45 Gy in 5 fractions is conventional fractionation, but it is not as effective for stereotactic treatments. 54 Gy in 30 fractions is appropriate for primary brain tumors, but suboptimal for brain metastases. According to the ARTOB 9005 trial, single fraction SRS at 1824 Gy provides high local control rates with manageable risk of necrosis. Question 6. Scenario-based. Management of radiation recall dermatitis. Dr. Patel is treating 58-year-old woman with metastatic breast cancer who previously underwent whole breast radiation therapy 50 Gy in 25 fractions 6 months ago. She recently started chemotherapy with gemcitabine and now presents with sharply demarcated erythematous rash on the previously irradiated breast. The patient is distressed and concerned about the rash worsening. What is the most appropriate next step in management? A. Continue gemcitabine and treat the rash symptomatically with topical steroids and antihistamines. B. Hold gemcitabine temporarily and initiate anti-inflammatory treatment with corticosteroids. C. Switch to an alternative chemotherapy agent as gemcitabine is contraindicated after radiation. D. Perform biopsy to rule out recurrent cancer before making any treatment changes. Answer: B. Hold gemcitabine temporarily and initiate anti-inflammatory treatment with corticosteroids. Explanation: radiation recall derma-TRD is an inflammatory skin reaction triggered by chemotherapy agents like gemcitabine, doxorubicin, and taxanes in previously irradiated areas. Management involves holding the offending chemotherapy agent temporarily, using topical or systemic corticosteroids to inflammation, restarting chemotherapy cautiously after symptoms resolve. Option is incorrect because continuing gemcitabine may worsen symptoms. Option C is incorrect because gemcitabine is not absolutely contraindicated after radiation but requires careful use. Option D is incorrect because biopsy is unnecessary unless clinical suspicion of recurrence exists. This aligns with NCCN guidelines for managing chemotherapy-induced toxicities. Question 7. Tumor hypoxia and its impact on radiation therapy. Tumor hypoxia is a significant factor influencing the effectiveness of radiation therapy. Which of the following statements regarding tumor hypoxia and its implications is most accurate? A. Hypoxic tumor cells are more radiosensitive due to increased DNA damage. B. Oxygen enhances radiation-induced DNA damage by promoting free radical formation. C. The oxygen enhancement ratio OA is approximately 1.0, meaning oxygen has little impact on radiosensitivity. D. Hypoxia primarily affects early responding normal tissues rather than tumor control. Answer: B. Oxygen enhances radiation-induced DNA damage by promoting free radical formation. Explanation: tumor hypoxia reduces radiosensitivity, making tumors more resistant to radiation therapy. Oxygen enhances DNA damage by stabilizing free radicals, increasing radiation-induced cell kill. Oxygen enhancement ratio O equals 0.53. Option is incorrect because hypoxic tumor cells are radioresistant, not radiosensitive. Option C is incorrect because OA is significantly 1.0, showing oxygen's critical role in radiosensitization. Option D is incorrect because hypoxia primarily affects tumor control, not early responding normal tissues. Clinical strategies to overcome hypoxia include hyperbaric oxygen, hypoxic radiosensitizers, and dose escalation, e.g., hypoxia targeted boost. Question 8. Radiotherapy in prostate cancer. Hypofractionation versus conventional fractionation. 72-year-old man with low-risk prostate cancer, ESOL 6.2 in GML, Gleason score 3.3 TC, is considering external beam radiotherapy EBRT. The radiation oncologist discusses different fractionation regimens, including conventional fractionation, 78 Gi in 39 fractions, and hypofractionation, 60 Gi in 20 fractions. Which of the following statements regarding hypofractionation in prostate cancer is most accurate? A. Hypofractionation leads to higher rates of gastrointestinal, GI, and genitourinary GU toxicities without any oncologic benefit. B. The AB ratio of prostate cancer is high, making it unsuitable for hypofractionation. C. Moderate hypofractionation, e.g., 60 Gi in 20 fractions, provides equivalent biochemical control to conventional fractionation with similar toxicity profiles. D. Ultra hypofractionation, e.g., 36.25 Gi in 5 fractions, is associated with significantly worse late toxicity compared to conventional fractionation. Answer: C. Moderate hypofractionation, e.g., 60 Gi in 20 fractions, provides equivalent biochemical control to conventional fractionation with similar toxicity profiles. Explanation: prostate cancer has a low AB ratio 1.5, making it more sensitive to hypofractionation. Randomized trials CH-HIP, HYPRO, and RTOG 115 confirm that moderate hypofractionation is non-inferior. Conventional fractionation. Option is incorrect because moderate hypofractionation does not result in higher toxicity when appropriately planned. Option B is incorrect because low ratio makes hypofractionation effective. Option D is incorrect because ultra hypofractionation SRTE G 36.25 Gi in 5 fractions has comparable outcomes when delivered with modern techniques. Question 9. Total body irradiation (TBI) in stem cell transplantation. A 45-year-old patient with relapsed acute myeloid leukemia or MO is planned for an allogeneic hematopoietic stem cell transplant (HCT) with a conditioning regimen including total body irradiation (TBI). The transplant team must decide on the appropriate TBI regimen. Which of the following TBI regimens is most appropriate for myeloma? Conditioning: A. 2-Gyn, a single fraction as it minimizes long-term toxicity. B. 12-Gyn 6 fractions over 3 days combined with cyclophosphamide or etoposide. C. 18-Gyn 9 fractions over 5 days as it provides better tumor control. D. 4-Gyn 2 fractions as it reduces graft versus host disease GHD risk. Answer: B. 12-Gyn 6 fractions over 3 days combined with cyclophosphamide or etoposide. Explanation: myeloablative TBI regimens typically use 1-3.2 Gyn 6-8 fractions, ensuring tumor eradication and engraftment. Low-dose TBI G2-4-Gy is used for non-myeloablative or reduced-intensity conditioning. Higher doses 18-Gy increase toxicity without survival benefits. The EBMT and ASTRO guidelines support fractionated EBI to reduce pulmonary and GI toxicity while maintaining engraftment success. Question 10. Scenario-based. Management of radiation pneumonitis. 60-year-old man with stadium and non-small cell lung cancer SLCA completed concurrent chemoradiotherapy, 60-Gy in 30 fractions with weekly carboplatin paclitaxel 8 weeks ago. He presents with worsening dry cough, dyspnea, and low-grade fever. CT scan reveals patchy ground glass opacities in the irradiated lung field. What is the most appropriate management step? A. Empiric antibiotics for community-acquired pneumonia and reassessment in 1 week. B. High-dose corticosteroids. E.g. prednisone IMEG with prolonged taper. C. Oxygen therapy and referral for bronchoscopy to confirm bacterial infection. D. Initiate antifibrotic agents. E.g. pirfenidone to prevent radiation fibrosis. Answer: B. High-dose corticosteroids. E.g. prednisone IMEG with prolonged taper. Explanation: radiation pneumonitis typically presents 1-6 months post-radiotherapy with cough, dyspnea, and low-grade fever. Corticosteroids are the first-line treatment. Prednisone IMEG with gradual taper over 1-2 weeks. Antibiotics, option A, may be needed if bacterial infection is suspected, but empirical treatment alone is not sufficient. Antifibrotics, option D, are not standard therapy for radiation pneumonitis. Question 11. Role of proton therapy in pediatric radiation oncology. A 5-year-old girl with a newly diagnosed medulloblastoma is undergoing craniospinal irradiation (CI). Given her age, proton therapy is being considered. Which of the following is the primary advantage of proton therapy in this setting? A. It reduces acute radiation dermatitis compared to photon therapy. B. It eliminates the risk of secondary malignancies in long-term survivors. C. It reduces radiation dose to the heart, lungs, and abdominal organs. D. It increases the risk of local tumor recurrence due to its sharp dose fall-off. Answer: C. It reduces radiation dose to the heart, lungs, and abdominal organs. Explanation: proton therapy reduces dose to normal tissues, lowering risks of cardiac toxicity, pulmonary dysfunction, and secondary malignancies. It does not eliminate secondary malignancies, but significantly reduces their risk. Sharp dose fall-off does not increase local recurrence when planned correctly. Question 12. Post-mastectomy radiation therapy PRT in breast cancer. A 55-year-old woman with PTM invasive ductal carcinoma undergoes a modified radical mastectomy. Her pathology report shows 3 positive axillary lymph nodes and negative margins. Which of the following is the most appropriate recommendation regarding post-mastectomy radiation therapy PRT? ERT is not indicated since she has negative surgical margins. B. ERT should include the chest wall and regional lymph nodes. C. PRT is only indicated if she has 4 positive lymph nodes. D. PRT should be omitted in patients receiving adjuvant chemotherapy. Answer: but ERT should include the chest wall and regional lymph nodes. Explanation: ERT improves survival and reduces recurrence in patients with 1 positive lymph node. Standard ERT targets: chest wall, supraclavicular and axillary lymph nodes, internal mammary nodes. In select cases, according to ASRO and NCCN guidelines, ERT is indicated for PTN disease even with negative margins. Question 13. Scenario-based. Management of brain metastases. 62-year-old woman with non-small cell lung cancer SLCA presents with new-onset headaches and gait instability. MRI of the brain reveals 3 enhancing lesions in the cerebellum, the largest measuring 2.5 centimeters. There is moderate perilesional edema. Which of the following treatment strategies is most appropriate? A. Whole brain radiation therapy alone. B. Stereotactic radiosurgery SRS for all lesions with corticosteroids for edema. C. Immediate craniotomy for resection of all lesions, followed by systemic chemotherapy alone, as lung cancer is chemoresponsive. Answer: B. Stereotactic radiosurgery SRS for all lesions with corticosteroids for edema. Explanation: SRS is preferred for patients with forebrain metastases, offering high local control with reduced neurotoxicity compared to corticosteroids. E.g. dexamethasone are used to manage perilesional edema. Craniotomy, option C, is usually reserved for single large symptomatic lesions or cases require decompression. Question 14. Radiation therapy in esophageal cancer. A 58-year-old man with locally advanced esophageal cancer (TNM) squamous cell carcinoma is planned for definitive chemoradiotherapy with carboplatin paclitaxel and radiation therapy. Which of the following radiation dose fractionation regimens is most appropriate? A. 50.4 Gy in 28 fractions. B. 45 Gy in 25 fractions. C. 66 Gy in 33 fractions. D. 70 Gy in 35 fractions. Answer: A. 50.4 Gy in 28 fractions. Explanation: definitive chemoradiotherapy for esophageal cancer uses 50.4 Gy in 28 fractions based on RTOB 8501 and cross trials. High doses 66 Gy do not improve survival and may increase toxicity. Question 15. Brachytherapy in cervical cancer. A 45-year-old woman with FIGO stage IB cervical cancer undergoes external beam radiation therapy (EBA) with concurrent cisplatin. She is now scheduled for intracavitary brachytherapy. Which of the following is the most appropriate brachytherapy prescription? A. 7 Gy x 3 fractions to point A. B. 6 Gy x 5 fractions to point A. C. 10 Gy x 2 fractions to point A. D. 30 Gy in single fraction to point A. Answer: B. 6 Gy x 5 fractions to point A. Explanation: standard brachytherapy dosing for cervical cancer is 28 Gy and 4/5 fractions to point A. Single fraction or excessively high dose per fraction, option D, increases toxicity. Question 16. Postoperative radiation therapy in glioblastoma D. A 67-year-old man undergoes gross total resection of a glioblastoma. Pathology confirms ID wild-type GBM. Which of the following postoperative radiation therapy regimens is most appropriate? A. 60 Gy in 30 fractions with concurrent temozolomide. B. 54 Gy in 30 fractions with adjuvant temozolomide. C. 45 Gy in 25 fractions with concurrent temozolomide. D. 30 Gy in 10 fractions with adjuvant chemotherapy. Answer: A. 60 Gy in 30 fractions with concurrent temozolomide. Explanation: Stop protocol 60 Gy plus concurrent temozolomide is the standard for GBM. Our doses 45 Gy are used for elderly patients or poor KPS patients. Question 17. Radiation therapy for soft tissue sarcomas. A 50-year-old woman with a 10 cm soft tissue sarcoma of the thigh undergoes limb-sparing surgery. The margins are 1 mm. Which of the following is the most appropriate adjuvant radiation regimen? A. 50 Gy in 25 fractions preoperatively. B. 6066 Gy in 3033 fractions postoperatively. C. 45 Gy in 25 fractions postoperatively. D. No radiation therapy, as surgery achieved negative margins. Answer: B. 6066 Gy in 3033 fractions postoperatively. Explanation: postoperative RT 6066 Gy is indicated for close or positive margins after surgery. Preoperative RT, option A, 50 Gy is an alternative but is given before surgery, not after. Question 18. Proton therapy in lung cancer. A 65-year-old man with stage ESLC undergoes chemoradiotherapy. Due to his poor pulmonary function, fuels 40% proton therapy is considered. Which of the following is the primary benefit of proton therapy in this case? A. Better local control compared to photon therapy. B. Reduced lung dose, lowering the risk of radiation pneumonitis. C. Increased radiation dose delivery to the tumor. D. Shorter treatment duration compared to photon therapy. Answer: B. Reduced lung dose, lowering the risk of radiation pneumonitis. Explanation: Proton therapy reduces radiation exposure to normal lung tissue, decreasing the risk of radiation pneumonitis. It does not improve tumor control compared to photons, but it reduces toxicity. Question 19. Reirradiation in head and neck cancer. A 58-year-old man previously treated with 70 GI for oropharyngeal cancer now has a local recurrence. The tumor board considers reirradiation. Which of the following factors most influences the decision to proceed with reirradiation? A. Time interval since prior radiation. B. Patient's HEV status. C. Tumor allele expression. D. Presence of distant metastases. Answer A. Time interval since prior radiation. Explanation. Reirradiation is more feasible if the disease-free interval is 2 years. HPV status. Option B affects prognosis but not reirradiation feasibility. Question 20. Scenario-based. Radiation recall dermatitis. 67-year-old woman with breast cancer received radiation therapy, 50 GI in 25 fractions. 2 months later, she starts doxorubicin chemotherapy and develops painful erythematous rash in the previously irradiated area. What is the most likely diagnosis? A. Radiation recall dermatitis. B. Radiation-induced fibrosis. C. Acute radiation dermatitis. D. Chemotherapy-induced cutaneous toxicity. Answer A. Radiation recall dermatitis. Explanation. Radiation recall dermatitis occurs when chemotherapy re-triggers an inflammatory reaction in previously irradiated skin. Doxorubicin, paclitaxel, and gemcitabine are common triggers. Question 21. Scenario-based. Adjuvant radiation in breast cancer. 55-year-old woman undergoes breast-conserving surgery for 2.8 centimeters per her invasive ductal carcinoma with 2 positive axillary lymph nodes. She receives adjuvant chemotherapy and is now planned for radiation therapy. Which of the following is the most appropriate radiation therapy plan? A. Whole breast radiation CertMedbry alone to 50 GI in 25 fractions. BOR plus boot to the tumor bud. BOR plus regional nodal irradiation. RNI. D. No radiation therapy is needed since she had systemic therapy. Answer. BOR plus regional nodal irradiation. RNI. Explanation. Patients with 1-3 positive nodes benefit from regional nodal irradiation to reduce recurrence and improve survival. Tumor bed boost is usually added for younger patients or close margins. Question 22. Stereotactic body radiation therapy SRT in early-stage lung cancer. A 72-year-old man with severe COPT was 35%, has a 2.5 centimeters stage A SLC but is not a surgical candidate. Which of the following is the most appropriate radiation therapy approach? A. 60 GI in 30 fractions of conventional radiation. B. Stereotactic body radiation therapy SRT 50 GI in 5 fractions. C. Palliative radiation therapy 30 GI in 10 fractions. D. No radiation therapy and monitor with imaging. Answer. B. Stereotactic body radiation therapy SRT 50 GI in 5 fractions. Explanation. SRT is the standard of care for inoperable early-stage SLC, offering high local control, 90%. Conventional RT, option A, has worse outcomes. Question 23. Whole brain radiation CertMedbry in brain metastases. A 60-year-old woman with metastatic breast cancer developed widespread brain metastases, 10 lesions with mild cognitive symptoms. Which of the following is the most appropriate treatment approach? A. Stereotactic radiosurgery SRS alone. B. Whole brain radiation CertMedbry. Systemic chemotherapy alone. D. Neurosurgical resection. Answer. B. Whole brain radiation CertMedbry. Explanation. CertMedbry used for multiple brain metastases, 10 lesions or extensive disease SRS. Option A is better for 4-5 lesions to reduce neurotoxicity. Question 24. Adjuvant radiation for prostate cancer. A 65-year-old man undergoes radical prostatectomy for Gleason 4 for prostate cancer. His postoperative PSA is undetectable, but surgical margins are positive. What is the best approach for radiation therapy? A. Immediate adjuvant radiation therapy. B. Salvage radiation therapy only if PSA rises. C. No radiation therapy unless local recurrence is seen. D. Whole pelvis radiation therapy with androgen deprivation therapy. Answer A. Immediate adjuvant radiation therapy. Explanation. Positive MARD equals E recurrence risk. Adjuvant RT improves survival. Salvage RT Option B is used if PCOS arises after initial undetectability. Question 25. Palliative radiation in spinal cord compression. A 70-year-old man with metastatic prostate cancer presents with new onset lower extremity weakness. MRI shows spinal cord compression at T. Which of the following is the most appropriate next step? A. Immediate high-dose steroids followed by palliative radiation therapy. B. Surgical decompression followed by radiation therapy. C. Chemotherapy alone. D. Watchful waiting since he has metastatic disease. Answer. B. Surgical decompression followed by radiation therapy. Explanation. Surgical decompression is preferred for patients with good performance status. Steroids plus RT. Option A is used for poor surgical candidates. Question 26. Oropharyngeal cancer and HEV status. A 50-year-old man with a 30-pack year smoking history is diagnosed with HPE-positive, stayed-Rome oropharyngeal squamous cell carcinoma. Which of the following treatment approaches provides the best survival benefit? A. Radiation therapy alone. B. Concurrent chemoradiotherapy CRT with cisplatin. C. Induction chemotherapy followed by radiation therapy. D. Surgery followed by radiation therapy. Answer. B. Concurrent chemoradiotherapy CRT with cisplatin. Explanation. HPV-positive oropharyngeal cancers respond well CRT, cisplatin plus radiation. Radiation alone. Option A is inferior for locally advanced disease. Question 27. Radiation therapy for rectal cancer. A 58-year-old man with C2N rectal cancer is planned for neoadjuvant therapy. Which of the following is the most appropriate preoperative treatment? A. 25 GI in 5 fractions short course radiation. B. 50.4 GI in 28 fractions with concurrent chemotherapy. C. Surgery first, then adjuvant chemoradiotherapy. D. Chemotherapy alone. Answer. B. 50.4 GI in 28 fractions with concurrent chemotherapy. Explanation. Long course chemoradiation 50.4 GI is standard for locally advanced rectal cancer. Short course RT. Option A is an alternative but less common in the US. Question 28. Radiation for pancreatic cancer. A 65-year-old woman with locally advanced pancreatic adenocarcinoma, unresectable, is planned for radiation therapy. Which of the following is the most appropriate radiation dose and technique? A. 50.4 GI in 28 fractions with concurrent chemotherapy. B. 25 GI in 5 fractions of stereotactic body radiation therapy SRT. C. 70 GI in 35 fractions. D. Palliative radiation 30 GI in 10 fractions. Answer A. 50.4 GI in 28 fractions with concurrent chemotherapy. Explanation. 50.4 GI with chemotherapy improves local control in unresectable pancreatic cancer ART. Option B is considered for borderline resectable tumors. Question 29. Toxicity of whole brain radiation at which of the following is a well-known late toxicity of whole brain radiation radiation pneumonitis. B. Radiation recall dermatitis. C. Cognitive decline and memory loss. D. Pulmonary fibrosis. Answer. C. Cognitive decline and memory loss. Explanation B. Associated with neurocognitive decline, especially in long-term survivors. W is an option. Question 30. Proton therapy in pediatric brain tumors. A 7-year-old child with a medulloblastoma is planned for radiation therapy after surgery. Which of the following is the main advantage of proton therapy in this case? A. Increased tumor control compared to photon therapy. B. Reduced radiation exposure to developing tissues. C. Shorter treatment duration. D. Lower overall treatment cost. Answer. B. Reduced radiation exposure to developing tissues. Explanation. Proton therapy spares normal brain structures, reducing long-term cognitive toxicity. Not superior in tumor control, but reduces side effects.